Hello, everyone, and welcome to UCL. I'm Sonia Johnson. It's brilliant to see you all here. Well done for getting out on a Monday night, which so few people seem to do nowadays. It's fantastic to see very decent audience in person on Monday evening here. So I'm the director of the Mental Health Policy Research Unit, the NIHR funded. As you know, we're called the Policy Research Unit in Mental Health now, but I keep forgetting. But we are a unit that provides evidence to inform policy at the Department of Health and Social Care and NHS England. And we are one of your hosts this evening, along with the UCL Division of Psychiatry and the Mental Health. Unfortunately, Andre, the mental health, isn't well, so he isn't here this evening. But hopefully, we're trying in several different ways to record this. Poor Kirsten, who's here at the front, has set up 3 different systems to try and make sure we get a good recording. So hopefully, we will have recorded the whole event so that people who aren't able to make it can hear the discussion with our very fine panel, whom we're delighted to welcome this evening. So this follows on from 3 pieces of work that the Policy Research Unit was commissioned to do in the last couple of years. One is an umbrella review, which is a review of all the systematic reviews, so bringing everything together, of all the evidence on paid peer support. And that was published about a year ago. And then there are 2 further papers, which were led by our lived experience researchers in collaboration with the whole PRU team, show qualitative interviews with peer support workers around the country, exploring their roles, how they fit into the NHS and the voluntary sector, where they work, and what they do and how they get on doing it. Those 2 papers have just recently come out in preprint, so the draft manuscripts are available to read, although they haven't yet been peer reviewed, so they may change. So after the event, we'll send you the links to those papers, and in particular, Karen and Bryn, among our panelists, were very involved in doing that work. So what they'll say, as was Patrick, our chair, and quite a few other people here. So what they say will be drawing on that piece of work we've done. Okay, so I'm going to hand over now to our indomitable chair for the evening, Patrick, who is going to keep order for the rest of the evening and make sure that we finish in plenty of time for the refreshments outside. So there's free wine, beer, and soft drinks, and networking is a very important part of this evening. So we do urge you to stay for a chat. Okay, so over to Patrick, who's one of our lived experience and equality diversity leads in the Policy Research Unit and across a variety of projects that we've done UCL in the Division of Psychiatry. Thanks very much, Patrick.
I'm really, really honored to be facilitating this session. I hope it's going to be an interactive, engaging, meaningful discussion, and I would encourage the audience to ask questions. So please raise your hand when you feel like you do need to. So I'm going to start off with Mel. So we have Mel Ball, who started her career as a peer support worker and is now Director of Lived Experience at the Midlands Partnership University NHS Foundation Trust. And she's providing insights into the role of lived experience in shaping mental health care and policy. And it's really, really exciting and honored to have you be with us this evening. I think I'll just go straight on, and I have a question for you, and I have to read this because I wrote a very long question. So, what are the priorities from an NHS leader's perspective for integrating peer workers into local mental health systems?
Such a great question. I'm going to have to hold this slightly close to me so it looks a bit like a talking box. It is. I think there's a few things for me. So understanding peer support within what's now more increasingly being described as the broader field of lived experience feels quite important. We're seeing lots and lots of guidance from NHS England, from thought bodies, from pressure groups coming out in terms of understanding how lived experience needs to be woven into so much of what we do as providers nowadays. There's a variety of roles springing up, such as patient safety partners, which relate to the patient safety incident recording framework, which is our new way in the NHS and provide a world of understanding safety and when safety goes wrong, usually. There's so much co-production in the role of lived experience in frameworks like the Patient Care Race Equality Framework. In terms of thinking about peer support specifically in terms of provision, we can see the Culture of Care programme, inpatient mental health transformation, loads and loads of initiatives and areas that are going to be a real focus for us seem to have peer support right at the centre, which feels really exciting. For me, in my own career and journey, I think I saw a really big shift come when the long-term plan for mental health really boldly and bravely said, we expect to see peer support, but not only do we expect to see it, actually these are the numbers and here's the funding to make it happen. And that felt to me like a really different way of emphasising the importance of those roles and how much providers felt able to move ahead on the agenda. So, for myself, I would say I saw a big upswing in people talking about, understanding, putting energy into making peer support roles happen. And it's important to say that, I'm sure plenty of folks will be aware the long-term plan for mental health also really emphasised the role of community partnerships. And so it wasn't just the idea that peer support workers need to spring up within the walls of statutory organisations or provider organisations, but also that we think about the full pathway of where our communities might most need to access support. And of course we know, and the research suggests that those who have the least equitable outcomes may well not find what they need within statutory systems and within what provider organisations have to offer. And in fact, the healing or the recovery, if you choose to use that language, may well happen in the context of the person's more organic community. I think for me, and I wrote a little bit about this a few years back, Bill Moyer's model of social activism is a really interesting model for considering how those things intersect. So often we hear, oh, our peer support's done by the third sector, or our peer support workers are in-house employees. And actually, those are two distinct models. I think they both have absolute richnesses to offer, really important roles to play, as I said, perhaps particularly for people whose outcomes are less equitable. But for me, it's a both and, because I think sometimes the really important grassroots organisations whose identity set might not be organised around mental health, but might be around cultural identity or sexuality or gender or another aspect of who somebody is, those organisations might not be able to influence the inside of the big institutional based, older, perhaps NHS or other provider organisations that are down the road and sometimes who most need to go on their own recovery journey to serve communities well. So I think that there's loads more I could say, but I'll probably leave it there and say I'm loving what we're seeing coming from the centre with it written through the middle like a stick of rock. Really appreciating the opportunities we've had to push the mantle further, thanks to secured funding from the targeted new monies for mental health, and I'm really appreciating seeing community partnerships flourish as a result of some of the other bits of guidance there, and a both-and model of inside the system, outside the system, far from the system and closer to it.
Wow, thank you. And well, I do have a number of follow-up questions, but in the interest of time, I will probably leave it for later. But thank you for starting the conversation, and I think there is a lot we can talk about as well. I'm more interested in around the community engagement, community involvement. And again, I guess going with my awkwardness, I will point at someone and say Braymore, but then I remember that Braymore is sitting over that side. So Braymore Lloyd Evans, I'll call him Brain, and Brain is a colleague of the Mental Health Policy Research team and joint head of the Department of Epidemiology and Applied Clinical Research at University College London. And he's had a leading role in most of the policy research projects on peer support, so it's really good to have you here this evening. I have a question for you, and in terms of what does the current research evidence base suggest about how we should deploy peer workers in mental health care?
Thanks, Patrick, and thanks for sticking to the question we agreed rather than changing it as you've been threatening to all night. So, hi everybody, thanks for coming, it's really nice to see you. So Sonia mentioned some of the work we've done in the Mental Health Policy Research Unit, and the umbrella review in particular was a valiant attempt that we made to try and draw together all the evidence from research about mental health peer support. And it turns out there's quite a lot really, so the umbrella review included 426 papers on mental health peer support from, I think it's 35 systematic reviews, and 23 of those reviews were trying to evaluate the effectiveness of peer support models. So there's a ton of work been going on really, and a lot of this is over the last 20 years. But despite all this, the results that we found and the conclusions we were able to draw were kind of frustratingly inconclusive really. There are a whole lot of outcomes that were evaluated in these studies, but they often showed mixed evidence. One trial would say one thing, another. Systematic reviews had different conclusions. And I think that reflects actually that there's a huge variety of different types of care and support that are being provided by peer workers who are also working in a huge variety of settings. And the more I kind of reflect on this and we do the work, I think this treating the idea that peer support is a single intervention and asking, is peer support effective, is not actually a helpful question. That peer workers do a whole lot of different things, some of which are likely to be more effective than others in different contexts. And I think kind of when we talk about other types of mental health care, we don't say, are nurses effective, are psychiatrists effective? We say, how can nurses and psychiatrists work effectively? And I think that's the question we need for peer support workers as well. But what I'd like to do just briefly, just to sort of kick off some starting points that you might want to come back to, is to flag up three sort of different types of peer-delivered care and support that exemplify different ways it can be done, which have some of the sort of stronger research evidence and look like some promising ways forward. So the first is in our umbrella review, we found some really promising evidence about peer support in perinatal mental health care, so for either for pregnant mums or mums with new children. And the peer support there was generally brief, so less than 3 months, just a few sessions, not very structured, but quite a lot of information giving, plus emotional support and normalising emotions and experiences that the mums were going through. And I guess it's interesting there that the peer workers had 2 points of connection with the person they were supporting, didn't they? There's the experience of illness, but also the experience of being a new parent. And maybe that's telling us something interesting about how lived experience can work well when there are multiple points of connection. The second one I wanted to flag up is peer-delivered structured self-management programs. So things like relapse prevention planning, recovery planning. And there's really good evidence from the States there of RAP plans, wellness recovery action plans, can help recovery. And a trial that we did in the UK that was led by Sonia and using a recovery workbook that was developed by Julie and colleagues for people leaving crisis home treatment care also seemed to help improve recovery and less reliance on acute care and coming back to crisis care. We know that self-management is underprovided in mental health care generally and with support, and it seems like something that peers can do well. And then the third area I'd like to flag up is just some really interesting studies from America just over 20 years ago now, where peer workers were employed as case managers within assertive community teams or assertive outreach teams. And there was a handful of studies, nearly all of which seem to show that the outcomes were at least as good for the peer workers as for the clinicians who usually provide that role. And that research doesn't appear to have sort of gone anywhere really. It hasn't led to massive service change, but I think it is really interesting about in what other roles could peers do these kind of general care jobs, whether it's as support workers, as care coordinators, as case managers. And I think there's more research needed there. So that's just 3 examples. A couple of reflections just to finish. I made the point that I think Mel has just made more eloquently than I would have about actually not all sorts of peer support are that amenable to research, but that doesn't mean they don't have value. And I think particularly peer interventions that are outside of statutory services that have a strong community base, a lot of mutual support, are just certainly hard to do trials with, but that doesn't mean they're unimportant. So research evidence is only one thing that commissioners and service planners need to take into account. But I think if we're thinking about what could be provided within statutory services and within the NHS in England, there is a sort of the need to try and provide evidence-based care and make the best possible use of money. I think it still holds good for peer work just the same as everything else. So we need to try and find the most effective models. There'll be a lot probably in the literature that we found, may well be brought up today, about the need to provide organisational support for peers. And that's, I think, really important as it is for all staff. So you need good training, good supervision, good management support, good career opportunities. But that's necessary, but I think not necessarily sufficient to guarantee you're going to get good care. So we do still need to try and look at the most effective models. We've got some examples from research and some ideas about what that could be, but there's still plenty more to be done.
Thank you, Breen. And we don't have to go that far with the mic.
Excuse me, I should have asked this at the beginning. Could you explain what peer support is? I can guess, but can you just explain the objective of this and what peer support is? Is it peer support as in, people with mental health people, or the carers with carers? Which is the peer? I don't quite understand.
I think that's a very good question, and we should have started
Yes, please.
with that. And I'm not going to sit here and pretend like I'm an expert in peer support, because they are actually experts here. And I'm going to throw that question to our colleagues, because you are indeed the experts. That's why you're here tonight. So, what is peer support? Any one of you, please. Briefly.
Go on, Chicky.
I'm happy to answer that. Yes, so peer support is some practical. It's the support that's offered by people who have a shared experience in their life. Often, when in this context we're talking about people who have shared experience of mental distress or of using mental health services, or on a number of issues, they may well have shared experience of similar life struggles. But it's about drawing on that particular experience to support another person, to demonstrate, just to embody possibility, but also we train peer workers to offer practical social emotional support in a way that's safe, appropriate and effective in that particular context, drawing on the evidence that's around. It's not a professional, it's not got professional framework, it's drawing on experiential expertise and personal experience. So it might be a family member supporting another family member, it might be a young person supporting another young person, it might be somebody with a long-term health condition supporting someone else with a long-term health condition, it might be someone who's been through adverse childhood experiences, or it might be someone who hears voices supporting someone else. Anything else? Is that clear?
Not really.
You'll learn more.
Okay,
You'll
I'll
learn
learn more. Okay.
Yeah, I
The
think.
word peer is can mean many things.
Yes, and that's the
It does.
then that's the complexity that brings it.
So just to get back, well, we will get back to your question. Hopefully by the end of the evening, we would have had a firm, solid explanation of what peer support is and how it can be integrated in different forms, I guess. The next person on my list of our panel's speakers is I'm going to look at one of you randomly and assume one of you is Sharif Mussa. And well, Sharif Mussa is a dedicated mental health nurse with a very strong background in lived experience practice and peer support work, sharing a dual perspective grounded in lived and professional experience. So that is Sharif. And Sharif, I have a simple question, which hopefully is also tied to your question as well, which is how can peer support bridge the gap between lived experience and clinical practice and challenge traditional power dynamics while remaining conscious of the pressures in acute mental health settings? It's a long question, but
Thank you. Yes, I'm Sharif. Gosh, it's a great question, but I think I'll try and talk because I struggle. I'm a mental health nurse, but I do this work because I'm a peer support worker. So I don't think I would have become a mental health nurse if I didn't do peer support work. So I think there, in a nutshell, it kind of answers the question: how does peer support bridge? For me personally, it changed my life, and doing it now on a ward, it's kind of really challenging. I loved your question because my grandmother, before she passed away, and I told her I was doing mental health work and I was a peer support worker, she said, "What is peer support work? What is that?" You know, she's an old Rwandan lady, couldn't understand English, I'm telling her peer support. But she understood when I said, it's humanity. I recognize your struggle, whatever we can do from that point on. We can be peers, we can go on this journey together. On the ward, I see a lot of challenges for us as peer support workers, because I train peer support workers, so it feels like the work for me is a little bit closer to heart than some of my peer colleagues or some of my colleagues in the NHS. So I think the challenges are real. There are some lip service aspects to it where the system isn't quite ready to accept peer support work and does a lot of lip service. So I think if we can find a way of clinicians accepting their own lived experience and bringing it into work, it will certainly make peer support workers like myself and other peer support workers safer and feel more valued or connected to their work and be more integrated into the system. It's like magic, peer support. I can't say anything more to it, like how amazing peer support work is. But it's challenging and it's taxing. And I have to be very honest, I talk to peer support workers all the time. I'm in an acute setting, so I have peer support workers around me all the time and we're in tears. We cry about lack of supervision or attitudes towards the work that we do. There's a real lack of clarity. I loved your response. Because nurses, we don't get asked, you know, is nursing effective? We get told, do this training and you'll be better at that, you know. But peer support workers are sort of just thrown in and told, you know, use your lived experience, which is really kind of unfair. And so we need to find a way that we support peer support workers, that they're not just thrown in there. Like, I came from a security background, so you can imagine my doorman skills in the mental health ward, and they wouldn't have worked. So I really took opportunities that weren't always easy to find. So I didn't get opportunities from the trust that I was working in. For example, I'd go to external affiliate spaces of supervision to get, even if it's signposting, to do something like this, or do a peer open dialogue course, or do talk for health. But I think we need to find a way that we are helping peer support workers to get extra training, because it's not fair to be thrown into a system that is already kind of at its limits, it's triggering, and then we get told, go in there and do that work. So we need more support, and a real recognition as well. A sadness in me is that I work with clinicians who also have lived experience. So we talk about the bridging of the gap between patients and clinicians, but then there's a real disconnect amongst the clinicians who don't always share their lived experience. So there's a lot of I talk to a lot of colleagues or friends of mine who I don't see as clinicians, I just see them as friends, but there's this real thing where they see me as a peer support worker. So peer support worker is like my lived experience, the fact that I've been on a section, I've been on a ward, kind of makes me feel othered. And I don't say that in a small sense as if it's something playing on in my mind. It really shows up. So we need to make environments that peer support workers don't feel like I've got a lived experience with whatever that diagnosis is, and they can't use it because it becomes a real challenge to effective peer support. So I hope I'm on time. Trying to think, it's 4 minutes. To conclude, I think we've got a lot of stuff to do. There's a lot of positives. When I started peer support work, we were the only peers in A&E, I think. But now that's been around for 7 years, and I hear loads of peer support popping up in different pockets. But it's always something in the back of my mind that makes me think, gosh, I hope we're putting them in safe spaces. I hope we're not just putting them in, because the systems that we go in are often not nourishing, not safe. Supervision is very kind of medicalized, and it will happen. I mean, I've been a nurse for a year, and I think I've had about 6 supervision sessions, but I've had loads of peer supervisions. And I think that makes a great impact to me staying at work. So I think supervision as well, training, and just a system that recognises and not others the lived experience of peer support. I'll stop there, but I think it's 5 minutes.
Well,
Thank you.
thank you very much. And I just wanted to thank you for sharing your lived experience with us this evening. So thank you, Mussa. And sorry for it. Sorry. I'm getting a bit lost.
No, this is fine.
Yes. And someone that doesn't need any introductions at all is Karen Machin. And yeah, Karen is a researcher and carer peer support worker, and focusing on raising awareness of peer support needs, including being co-director at WICU, which is designed to develop and deliver training for peer supporters, including delivery for trusts. That's quite interesting, and which leads me to ask you a question. And Karen, can peer support fit with the drive to maximize opportunities of online and digital mental health care? And could research contribute to this?
Thank you, Patrick, for reading out the question as it was given to us. I've got notes because I've been studying how peer supporters use digital technologies for forever as part of my PhD study. So I could talk about it forever, so I've got notes to keep me to time. So I apologise for reading from this. There are 3 overlapping elements in the question that you asked. You talked about peer support, you talked about technology, and you talked about research. So I've divided that up into sections. And firstly, that first bit of the question was, can peer support fit with the online technologies, the digital? I'd like to flip that around and say, shouldn't that drive to digital be something that we have to, why is it something that we have to fit with? Shouldn't digital be fitting with us as peer supporters? As a personal example, 20 years ago, in a very difficult life situation, I looked for support online, and so were other people. We came together, we formed a group, and we're still in contact now, 20 years later. So should we call ourselves friends? I'm not sure about that. Some of the group might say that they're friends, but I think there's something about that we don't talk about the general stuff. We're still talking about that mutual situation that we were in, that shared situation, and the impact that that continues to have on our lives. So that, for me, is what peer support is, and that sharing of the mutual experience and the challenges that are related to that. We communicate through digital platforms, so I've never met those people in person. I don't even know what they look like, which is really odd. But it's the people that are important, not the technology. So I use that example, and it also provides a reminder that peer support isn't just about, as everyone said, it's not just about those paid peer support workers in services. It's so much bigger than that. So I think digital needs to fit with us, not the other way around. The second part of your question was around the opportunities of digital. And we know the benefits, including reduction of travel time, easy access for some people, cost benefits, reduced waiting times. But what do we mean by digital? And what benefits might we, as people with lived experience, rather than service providers or developers, want to consider? For example, many people value the anonymity provided by digital, and that's relevant to discrimination around mental health experiences. Pseudonyms enable people to hear discussions and access support around topics which they might feel very isolated with. Hearing voices, self-harm, sexuality, gender. Or look at the way that marginalised groups were able to mobilise on Twitter, for example. So we had Black Twitter and Mad Twitter. You know, there might not be specific digital mental health interventions, but they provided a community, and they had an impact on our own emotional well-being. But the world changes, as we know. Last week in America, we saw the tech oligarchs sat on the front row with more importance than their elected officials, and giving Nazi salutes or gaslighting us that didn't happen. Lived experience researchers in the US, so my peers, are already disappearing from our international networks and discussions to concentrate on the local battles as funding is stripped and diversity initiatives, which include those for disabled people, are shut down. There's increasing awareness of the resources that digital technologies consume. So the massive use of water and minerals contributed to climate change, and the labour of people in the global south traumatised by the moderation work, as described so vividly in the Data Workers Inquiry. There's increasing concern about data privacy and consent. Do we have anonymity when they're selling our data? And that's all aside from the more questions about AI. So that techno-solutionist assumption that we agree on the opportunities of digital maybe needs to be questioned. And finally, addressing that question of how can research contribute, I'd ask whose research? I'm at last seeing articles mentioning that people with lived experience need to be involved in digital mental health research. But I've not seen much thought about the expertise that peer supporters might contribute. Peer support isn't one thing, as everybody's said, it's paid, voluntary, one-to-one in groups, families, specific demographics, whole range of settings, prevention across health, social care, justice, and inter-communities. So how do researchers understand peer support in mental health when it is so varied and flexible? They want clear definitions, it's fair enough, but I'm still haunted by Shane Reed's 2006 question of what makes peer support unique. I push for a realist study to understand what works for who and how. And when it comes to technologies, when it comes to digital technologies, the researchers quite often refer to digital peer support. And all they mean is peer supporters helping someone to use the specific app in their trials. And those researchers only look at the acceptability and effectiveness of the digital intervention. They don't report on the specific impact of the peer supporters. So rather than digital peer support, I've named that peer supported digital interventions to be clear that it's not peer support as we know it, to involve person-led choice. So could research contribute? I repeat that it depends who's doing the research. I'm concerned that the money and the motives involved are pushing us towards the replacement of a medical model by a digital model and with the same people in charge. So in conclusion, I'd bring to our discussion tonight my reframing of your original question, Patrick. I'd ask, how can we support lived experience researchers to maximise the whole array of opportunities for peer support, including the use of online and digital platforms, while ensuring it retains its radical roots? Thank you. Sorry, I have to read that. I'm so sorry.
That's absolutely fine. I was assuming the clapping was because you said over to you, Patrick. So. Our next panel member, I think, just gives me, honestly, I'm actually trembling sitting next to Isaac right now. Well, one of my heroes, honestly speaking. And so, Isaac is an established community campaigner, co-production advisor, and a representative of Nyikavaranda. Love that name. A social movement that encourages support for one another through public living rooms, including hospitals, universities, and community spaces. And I know all this, but I had to pretend as if I'm reading, so I had to. And I have a question for you, Isaac. And how can we ensure peer support is accessible and helpful for all sections of the community? And what role do voluntary sector services have to play in this?
Big question. So first of all, as someone that cut their teeth in peer support spaces, it's really hard to say this. Get your hands off our peer support. I think we need to reclaim peer support. I think we need to be much more radical. There's something that's happened in this country that's gone a bit wonky. And we use words like wonky and comrades. So as someone that believes in peer support, I don't know how in the container of a very abusive system, so I think we all pretty much agree that mental health systems don't serve people very well. there are lots of abuse that happens, and that hasn't changed over the 20-something years that I've been accessing and surviving mental health services. If we think about the money and where the money's held around peer support, those very systems deciding how we organise peer support. If you think about us as a discipline or a movement, do we need to be thinking about our effectiveness? Do we need to be thinking about where the power sits? And I think we do. I think it's sometimes hard to be in a space with colleagues and say, have we got to the point where we need to reclaim where peer support came from? Has the systems of oppression really meant that we've moved far away from kind of where peer support can be most useful? We know that peer support often is white-centred in its approach. We know that it's often organised in a very systematic, capitalistic way that doesn't lead to really good outcomes for people. That's all really hard to hear, right? From something that's supposed to be so important and can be life-changing. So where do I find a space that actually makes the biggest difference? And I've been all of these kind of roles in my life, is handing it back to community. And I think Karen's right, peer support isn't the same as being a friend. It's in between being a friend and a bit of a stranger. But at Camaradas, we really believe accessing public spaces that everybody can access is really important. Really creating an opportunity to have conversations not based around challenges, but actually based around strength. So when people come into those places, if you see someone kind of struggling, ask them to do something for you is one of our principles. One of our principles is about mixing with people that don't sound and look like us. It's okay to be shit sometimes is another principle, because we all can get it wrong. And the principle that I love most of all is the one around having fun. And peer support is about having fun and having humanity for me. It's about connecting to somebody and something that we commonly share. Popping up in like kind of venues in public, you know, often we're hurried away by police and like, so imagine like, you know, tablecloths and lamps and sofas coming to your town square, and then people just come along and talk about the challenges. And the things that people talk about are not the things that come into mental health services and systems. They're actually talking about the things that make a difference. So I had a phone call with somebody last night who is another fellow Colorado, and they were feeling like they wanted to bring their life to an end. And I thought about kind of the time that was an experience for me. And I wouldn't go to a system that was traumatizing, you know, and they didn't go to a system that was traumatizing. They went to somebody in between a friend and a stranger, camaradas, and they talked about that. And by the end of that kind of conversation, they were okay enough to kind of call me today. They're still here because of that. And I think what I've learned is that we need to be much more open to being peers, being alongside, being in the uncomfortable, and being really honest about when we create these roles. And I don't know sometimes if what I am. So am I someone with lived experience, or am I someone with professional experience, or am I somebody just with experience? Is there a role to play in society for all of us? And when I first started kind of my journey in peer support, it was with a group of people that nobody wanted to work with. It was with people with HIV and AIDS. People actively didn't want to actually provide them with support. So the only people that would provide them with support were people that had the virus themselves. And I think there's a lot of learning that I took from those spaces, particularly around the role of having mental health challenges. If you've walked that path, you know what it feels and looks like. You can help other people walk that path. I think camaradas is a really funny thing, just pitching up in public spaces and talking to people for no particular reason at all doesn't seem that it would be very fruitful, but it's really fruitful because actually many people won't go to the spaces that we have engineered to be places where peer support should be an offer. I work at a local authority and they said, oh, like, we want to get a public living room in, we want to like systemize. And I was like, The worst thing that you can do is systemize something that's very natural. We have to invest in our local infrastructure, we have to invest in our local communities to lead some of this space, and all the things that my colleagues will say around kind of support and infrastructure and all those kind of things are really important, but there is a space for actually just people self-organising, people reclaiming and recentering where peer support really came from. It came from people just being alongside, people not needing all of the things that we've created around peer support. I hope I've answered your question, and it's quite critical of our own discipline, and I'm wondering if psychiatry and nursing would have been so mindful to critique its own practice, would we be actually in the same place we currently are? And I always invite our peer support community to critique its own practice. So what I now know as my own practice and journey is very different from where I want to go, but actually at a point in time things serve us really well when we evolve, and I think there is a need for us to continue to grow and evolve. And I see that in a world where there is certainly no more money, certainly no more hopes and visions for better mental health, peer support really playing a really strong role within that. And I think that we need to share our knowledge and expertise across the different types of lived experience knowledge that we have. We don't have single types of lived experience knowledge, we have multiple intersecting lived experiences. I'm gay, I'm brown, I'm disabled, I'm a suicide survivor, etc., etc. There will be people in this space that have those similar experiences. How can we connect? How can we support each other?
Well, thank you, Isaac. And now to our last speaker, and I had the pleasure of speaking to Julie before this session, so I do know who Julie is, by the way. And well, Julie is the director of IMROC, and I would love for you to just briefly describe what IMROC is, because I found reading on your website quite interesting. And you are, well, Julie is a leading advocate for recovery-oriented practices, with a focus on the use of peer workers to drive recovery-focused organizational change, which is quite a lot. And my question to you, apart from obviously telling us a little bit about IMROC, would be what research would you like to see done to enhance future peer support provision?
Thank you. The two things are quite separate. I'll start with the sake of it, because actually thinking about what research we need, you've already answered it. Every one of you's answered it to some extent. But the question that emerges really for me when we hear about the disparate and diverse nature of peer support is we could do with knowing where we're at around where peers are employed and where peer support happens, and how many people do find training helpful or have training, and how many people are volunteering and how many people are actually in paid employment, how many people get the support they want, how many people have the opportunities that they want. If we are really thinking about peer support as one thing, maybe we should be able to describe it. But the reality is it isn't just one thing. It's united by values. And the way that we can really define peer support is by the fact that it's the support that happens between people who have something in common, but also that it is really characterised by the values that have been associated with it, and which each person along here has talked about. You know, the values of mutuality, of sharing something, of learning from one another, the reciprocity, of being recovery focused together, building on strengths, but also being community facing, always thinking about how we can support people to engage within their own communities, whatever those communities might be, communities of their choice. Really, this is about enabling people to think about what progress means to them, what meaning means to them, what living well looks like to them, and to support them in that journey, but without resorting to professionally led theories and interventions. That's kind of as much as we know. When we look at the research, as Bryn was saying it, there's an awful lot of research, but there's not an awful lot of high quality research. And I think to some extent that's because we're trying to fit peer support into models which have been developed for other types of interventions. Peer support doesn't lend itself to randomised control because we're not actually quite sure what it is that peer support is. We need to be so clear about what we mean by peer support, who it's provided for, what the kind of support that's been provided for is, where it's being provided, for how long, and what difference it makes, and is that the difference that we were looking for? So I suppose I'd agree that there's a place for realist evaluation, for case studies, for really looking at, the thing we were talking about was some work that we're doing in IMROC. Increasingly, inequalities in health outcomes are found amongst communities who find existing mental health services, physical health services very hard to access. And they're constantly bombarded with surveys and questionnaires about what would work for them. And actually, one of the things we're doing in 3 different regions is looking at small communities of gypsies and travellers, of asylum seekers and refugees, of Chinese elders, Somalian men, people whose health outcomes are particularly poor. And in every case, they are coming up with different kinds of answers about the kind of support that they require. But in every case, the people they want to go for that support are people from their own communities. And they want those people from their own communities to help them to navigate the system and find their way to the kind of support that they want. They don't know what's available or where to go, for what they need. And that's a really big opportunity for peer support. As we move forward with the long-term plan, which Mel was talking about, as we start to think about systems, place, neighbourhoods, the big challenge is the size of the challenge, the fact that so many people have so many needs, they don't know where to go to get those needs met. Now, the health service, social care service is quite expensive, it's quite targeted, it's very treatment oriented, but actually what peers can really do is to support people to work out what's getting in the way of what they want from life, where they can find it, what support they need to get to access that. And actually one of the things we've done in IMROC again is to work with, across a whole region, 280,000 people. GPs were saying, we have too many people who'd have problems that aren't susceptible to medical intervention. They've got long-term health needs, they're either lonely or excluded or frightened. They ring the ambulance 5 times a week. They're in my surgery 3 evenings a week. We actually just employed 15 peer support workers and set up a local co-production group. Started with 20 people. In the end, 120 people were joining us every month. And we started running courses run with peer support workers, running them in libraries, theatres, health centres. We employed 15 peer workers, and those peer workers knew how to help people sort out housing, benefits, how to get the kind of support they needed. And we saw after 12 months, 100% return on investment. We'd reduced the use of primary, secondary, specialist social care services, and we saw significant improvements in health, physical health and mental health, and a reduction in loneliness. It just feels that wasn't an RCT, couldn't afford that, but it was a follow-up study, and I'd love to see more research into the role of peers in that really practical, supportive place. So I could talk for endless. There's so much more to do in this space, and at the moment it's so chaotic and so ill-defined and wishy-washy, and it feels to me as though we need to kind of not stop all the developments, but maybe just try and scope it out and stop being quite so ambitious and start to say what's happening here and what's happening here and what's happening here in more case studies, more realist approaches. Thank you.
Thank you. And that brings a close to the formal questions. So may our panelists please relax. I don't have any more formal questions for you. Like I said, I've actually got some questions for you. But in the interest of time, I think our audience members might want to ask a few questions. And before I allow people to ask questions, please ensure that your question is brief and directed to any members of the panel, or if it's general, that's fine, but let's be brief and let's try to keep one question per person at a time. I'm sorry to be so rude and direct. However, we saw an enthusiastic hand.
Thank you to the panel. It's very interesting to hear from the second speaker and then the last. And what we hear from the second speaker is that there is a morass of different research, and you can't really come to some kind of a single conclusion, right? On how to really guide how NHS will spend money on this. As a mental health NHS mental health governor, I see peer support brief being sent out by my trust, and it is very single dimensional. And in fact, if you look at your title of this event, Exploring Peer Support in Mental Health, I would say that there is no such thing as a peer support as a singular, but it should be a plural. And equally, mental health is also plural, because somebody with psychosis and somebody suffering from prenatal challenges, they're completely different. So when you want to do research to analyze what is useful, what could be good value that we should spend on, we need to first categorize, slice and dice the issues, the challenges. So, to you, since I can only say one comment.
Well, thank you, sir. Thank you, really. And I will open it to the panel.
Actually, could I just ask something?
Sure.
As we haven't got mics for the audience,
Yes.
I think there's only one microphone to pass around. Whether either you or the person answering can just summarise the question a bit
Indeed.
for our online later audience.
Thank you. And so, panel members, the question being directed to you is, first of all, in terms of peer supports, should really be plural, but also mental health, as it's got so many dimensions, and some of them have been directed around mental health, perinatal, postnatal, so many different aspects. Anyone care to answer that question? Briefly, please.
Start off. I mean, I think we're all in agreement on that in the panel, really, that you need to really kind of carefully describe what's going on in any peer support program, and think carefully about with whom and in what kind of service context it's being used, and that's really important. And it's a challenge, isn't it, that we have a new workforce in the NHS, really, and there isn't sufficient research to kind of guide and say this is always the best way to use peers. So I think it requires looking at research evidence and the best research evidence we've got where you can, but also then just thinking carefully about local need and constructing the best roles we can in the meantime, and then carefully looking at how is that working, for whom and why. So yeah, I think I've got no quarrel with anything you said. I think it's
Any other comments?
I think what's interesting that why are we feeding the base of research? So are we wanting to feed research as well, or are we wanting to do the the work by people, and is it counting the things that matter or doing the things that matter? And I sometimes think, oh God, we need to prove that peer support works, so we do wonky research that tells us very little about it, or leaves us in some doubt, and then we go on to do more and more and more. Actually, there is lots of lived experience knowledge that tells us lots of positive things about the role of peer support, and maybe we should just start elevating that knowledge to validate kind of research. And I think we should slow down trying to feed that beast and actually think about feeding it with the right sort of knowledge.
Thank you. An interesting question and interesting answers. So thank you. Just your question, please. Right at the back.
Yeah, thank you. It's been super interesting, and I guess I've sat. I'm a professor of psychiatric epidemiology, but I've also sat the other side in kind of supporting my daughter with eating disorder, and I had a peer support, and now she is a peer support. So, and which was the best thing, by far the only thing that helped and very eye-opening. But I just wanted to raise the issue that, and it's been mentioned about the role of safety, which is really important for, certainly with my daughter's role in that. And then at the same time forcing something into a system. What seems to happen is there's rules about who qualifies, and certainly within that, as a parent, you're only allowed to often tell other parents if your child has been deemed to recover, and the same for her. And it's like, how is that realistic? Is that right?
I'd like to answer that if that's okay, because it is a real challenge. Prepare. So we have we've been training. Sorry.
Summarise the question.
So the question is largely around who makes the rules about who can be a peer support worker and what they do, and how do we ensure safety is considered. I think the other thing that you bring up, which is what we hear all the time, is the anecdotal evidence. What we hear is, this was amazing, this was the one thing that made a difference, particularly for, I think, for younger people, finding somebody else who actually has found a way to live with things, whatever the experience is, live with similar experiences, to find a reason to live, to find some meaning in life, to continue to live, it can often be the most valuable thing. And it's, and actually I have to just say, I come from Nottingham, where the big awful homicides took place, and it sort of evoked this big response in social media saying, my God, we went so wrong, we need to have all professionals now, we can no longer have any non-professionals. And I think about Waldo, the guy who actually committed these awful offences, and the fact that he was terrified of taking medication. It really made a mess of his life. He couldn't study, he couldn't maintain relationships. And I think the value for him of having another guy from his own cultural background who experienced voices, who had found ways of taking medication in the right way, at the right time, at the right level, to be able to both live life and enjoy life. I'm just coming back to that. But I also wanted to say about safety. The problem is, when we're preparing peer-to-peer support, we have to think about where we're going to employ them. And so we can only train people in the kind of things that would enhance their own safety and the safety of the person they're talking to, whether that's their emotional safety, whether it's physical safety. they are considerations to be taken into account. Actually, the rules are made by the bureaucracies in which they work. So there are things, and the bureaucracy may well be, there might be some evidence underpinning that, and I think at the moment the more we can do research the better, but often when we're training people we don't give hard and fast rules, we talk about the pros and cons of different decisions or different forms of action.
I just wanted to cover off the point about Valdo, that actually peer support wasn't offered to him, and one can only imagine, as someone who sat on the independent review, I wonder about the racism that played into some of those decisions. And actually it was professionals that we invest in much more than we do peer support workers, So at the top of the pyramid, we know we invest in psychiatry, but they were all the people that let him down. And what would it have been like for Valdo to actually have someone that understood what it meant as a black man that was very studious to have an experience of human voices? There may have been a very different outcome.
Sorry, and I just wanted to add to what Julie was saying there about answering your question at the back before we come to Debbie. Great question, Debbie. But that issue around who's becoming a peer supporter and how the gatekeeping around that. So with you, we've been delivering training for peer supporters for 15 years, and over the time we've seen the people coming on the training change. So at one time, while the people who were coming on the training tended to be people who were coming from that lived experience perspective and were being trained and then recruited to being peer support worker posts, there was more risk around who was on that training. So we might have people who were still on inpatient units, perhaps still being referred to crisis services, but we could see the change in them from that day one when they were coming in with their heads down and not quite sure how to make eye contact with people, to the end of the training when actually they felt confident because they'd met other people who were experiencing those things. They gained confidence themselves and could then offer that back to somebody else in a paid role or in a voluntary role, but their lives moved on. I think what we're seeing now, and maybe it's the same at IMROG, is that we're seeing that trusts are doing recruit and then train. And they recruit the people who are a safe pair of hands. That's fair enough, it's public money, we don't want it wasted. But we're seeing a lot more people coming through who've got a first degree in psychology. And that changes, I think, the nature of peer support.
Thank you. And I think you might as well answer the second question.
I'm not answering Debbie. Debbie hears from me every single week, so I think you need to
So,
give somebody else.
is there money in recovery?
Can I just say that this research is based on paid peer support workers. The first peer support workers were unpaid, and they're voluntary.
Yeah.
And we came in to implement change within the system. Now, if you can use another different word for change, and that's shekels. Tired of the shekels. Now, right here, when I was going through stuff 10 years ago, Friday the 6th of June 2014, BME Equity and NIHR Time for Change, Time for Action. How many years are we going to be doing this? How many, really? And there's an awful lot of discrimination against those that have got lived experience. Whether he was on a panel, for the interview panel, it's a university of life, but when somebody's gone to university, psychology, psychiatry, or anything else, they really don't like anybody else that's got a tantamount of lived experience, just suggesting, what would make stuff easier. And that turns out to be internal communications. It is so fractured from one department to another department to another department. And the peer supporter is picking up the pieces. And now it's evolved somewhat, and we've got paid ones, and it's come from passion, which is really shafting the end user. What I have brought with me is my 5 R's. I've printed off a proper page of it, so I'll give it to you, but I'll read it. They stand for respectful, reciprocal relationship for remedy and recovery. With all the talk of involvement, community co-production, expert by experience, reviews on this, that and the other, time over time, come the same old excuse and delays. Ever heard a kiss? Me too. So keeping it simple, I came up with my 5 R's. It came out about after seeing 5 pins written on a boardroom wall, and I didn't think it was worth tuppence. Our voices as reps or individuals, those with lived experience, often used, abused, and cast aside. No change. I hold my hands out to both sides, to the end user and the service provider. By applying Grandma's 5 R's, we bring our hands together, joining both, actively facilitating change. Respectful, reciprocal relationship for remedy and recovery. If it's not respectful, it's not reciprocal, there's no remedy and recovery, and that's your relationship. And that seems to be, I've done an animation of it, don't worry. That's what it is, so let's bridge the gap. And I did go to the Queen Mary's Hospital a while back. There's a campaigns for 10 years to implement change. So 1 minute we've got campaign for change, co-production, having voices heard, and then we've got another one from NH in England with the local authorities. What do people want for their services, keeping it local? And we'll have this going on for another 10 years. So when will we get the gold standard? Because it all applies to people.
Well, thank you. A very, very, very good question.
I was Nyikavaranda, so 7 years ago, first came about, loved it. All right, Tony should have been here doing a sing-song.
Well, thank you. This is really going to be brief. Any final comments from the panel? Please. Sharif.
Thank you. Not so much to what just something, but just to, I'm thinking of my peers that are not here, or the peer support workers, the people that have supported me that aren't here, the network spaces with allies, peer supporters that, I think you asked the question, I think she's gone from the background there. I use peer support with my children, I have 4 children, and it's incredible. And I think a lot of people will talk to me, even my commission colleagues, who don't explicitly use their lived experience to practice peer support. And thinking about is, when do you know when it feels safe? It's an instinct, I think. When you feel safe with somebody, then you can do that peer support with them. But yeah, it's been an interesting evening thinking about, even like the comment about research. Being in Northmead in A&E, I was part of that research that I felt like, well, what's going on? How do you research peer support work? I've never quite understood how you research peer support work, but I understand the value behind it. And there's one thing that, as a peer support worker, I find this still remains in peer spaces. We're not always on the same page as peer support workers, and that kind of allows the system to get in between us and makes it harder for us to climb up and actually implement the change. So that's something I wanted to say before we finish. But yeah, thank you for this.
Thank you. Just got time for one last question, maybe two, depending how briefly. It's very brief.
Hi. Just quickly on peer support in workplaces. I assume that's something that you would do. Particularly in like quite high up in like corporations, law firms and that kind of thing. There can be a lot of stigma, obviously, around mental health. So if you have peer support in those kind of places, I was wondering what your stance was on. It seems to be sort of a chicken and the egg situation where do you work first on educating people in mental health and changing the stigma and then introducing peer support, or do you implement the peer support in the hope that it changes the mental health culture in the law firm or organisation, whatever it is? Yeah.
Thank you. And please, very briefly, 30 seconds.
30 seconds, I want 3 hours.
Thanks, Patrick. We've done loads of work with organisations, and I think that getting in there and finding the key people who've got lived experience and ensuring that they've got the skills and the confidence to then start sharing it enables change to be made. So getting in there and getting on with it, not waiting for, let's train the whole workforce. It doesn't work like that. Just getting in there and doing it. And we do work with the police. So, the police forces being able to implement peer support, that sounds very countercultural, but it really did work.
Thank you.
30 seconds.
It was enough. I will have to bring it to a close, but I think one last question.
Hello. So one of the most cherished things about peer support I'm hearing from the panels is that it's varied and it can be free as well. And this makes me think very much about the land and the reciprocity that we get when we tend it carefully and tend it well. It's a question that's on my mind, and I don't think it's going to go away very easily, but I hope we can get an answer to somewhat. And I wouldn't put it just to the people with lived experience, I put it to the people who don't, perhaps more so. That is, how can lived experience workers enter the workforce without becoming owned, much in the same way that our structure around land has become?
I guess one of the things I'd like to come back with is, that I think everybody, I would say everybody, everybody here, I think in the organisation I work for, we've got 95 people working for us, and every single person has their own lived experience. In the surveys we've done of trusts, even though only around 10 to 15% actually use their lived experience in their practice, between 45 and 62% of staff in mental health organisations in a confidential survey admit to having their own experience of mental health challenges. So I think it's a really spurious divide. I really think that I think we've moved a long way. I may be completely wrong. I think one of the biggest challenges we've got is to enable all people working within services to use their lived experience, to draw on it, to really emphasise shared humanity, to stop to bring down the barriers between people who are using services and people providing them. The real difference is that peer support workers are not, I would say, although there are many research projects which actually evaluate peer support where peers are providing a professionally designed intervention, that to me doesn't fit with the definition of peer support being essentially about drawing on your own lived experience to support another person. The difference is you're there purely with that expertise, whereas other professionals don't. But I don't think, and there's a massive problem with distorting, co-opting peer support where you take it into the NHS, and that might be what you're talking about. But I know, for me, when I'm admitted to an acute ward, I would like to have the option to have peer support. I don't want it denied to me just because this is an NHS place. I think we should all have the opportunity. The other thing is, I don't think we should be so frightened. I don't think peer support workers are necessarily any more vulnerable than any other member of staff. Let's get them into those areas. Let's employ them, provide all staff with supervision. What's good for peer support workers is good for everybody. And Emma Watson's PhD, really interesting. What she looked at was how peer support workers worked within an NHS trust. And what she found is peer support workers are ingenious at maintaining their distinctive and really principled commitment to their values, even in the most unimaginable circumstances. They will remain peer workers and they will find imaginative ways of carrying on that work. That's not saying it's all that. It's giving you hope as a final.
Yeah. Thank you. I'd like to say a big thank you to our panel members. Unfortunately, time has really flown, and I know these are conversations hopefully we can have once we go into the networking session. But as I say to everyone, I'm here for the drinks and the chatter. So if you don't mind us actually going just across, there's drinks, there's meals, and there's opportunities to discuss further. But I just wanted to say a big thank you to our panelists. And also, I think a big thank you to all of you, because you had some very interesting comments and questions. So thank you as well.